session where we'll be talking about likely questions in your NICT exam. So broadly, we'll be looking at the topics which have high likelihood of landing up in exam based on the trend of the previous year's papers. Obviously, this is just attempts to identify the most high yield topics for your exam. So it would be best to take it with a pinch of just make it the priority areas of your revision program. Just make it a priority area of your revision programs and take it accordingly. So first topic which I would like to highlight in this context is the acid-base homeostasis, the acid-base homeostasis topic. And so I've given you a model question here. So typically in this acid-base homeostasis question, you get the ABG values where you have the value of pH, where you have the value of PCO2, and you have the value of bicarbonate. In some cases, you might also be asked to comment upon the anion gap. Now, in these questions, what you have to keep in mind, the normal values will not be provided. The normal values will not be provided. So you have to know the normal values for each of these. For example, for pH, the normal value should be 7.35 to 7.45. For PCO2, the normal value should be 35 to 45 millimeter of Hg. For the bicarbonate, the value should be 22 to 26 milli equivalent per liter. And for anion gap, the value should be 8 milli equivalent per liter. Okay, and now when you're calculating the anion gap, here you have to keep in mind that the parameters to be used are concentration of sodium, and this has to be compared with concentration of chloride and the bicarbonate. These are the parameters which have to be used, normal value being 8 milli equivalent per liter. Alright, now based on the normal values that we have just mentioned here, you have to identify the nature of acid base disorder. All right, so very quickly I'll take a look here. I'll show you a flow chart which helps you to identify the simple acid base disorders. All right, so we have this very simple flow chart which helps us to identify the different types of acid base disorders. So from the arterial blood sample, we look at the pH. Based on the pH, you identify where you are looking at acidosis. Less than 7.4 will be acidosis, or you are looking at alkalosis. More than 7.4 will be alkalosis. Now, if you're looking at acidosis, there are two possibilities. Either bicarbonate value is low, it is less than 24 milliequivalent per liter. In this case, it is called as metabolic acidosis. However, if the primary finding is that PCO2 value is more than 40 millimeter of Hg, in that case, the respiratory acidosis becomes your diagnosis. Now, in some of the cases, you are asked about the compensation, whether the compensation is there or not. Now, if your primary diagnosis is based on the finding of bicarbonate, then you look at the PCO2 value again. Now, there are two possibilities. PCO2 value was not elevated as it should have been in acidosis. Then there are two possibilities. Either it is normal or it is going in the opposite direction. If it is normal, then there is no compensation. If the second parameter is in the normal range, the compensation is not there, which happens in the acute cases. However, instead of the value being higher than 40 millimeter of Hg, if the value comes out to be less than 40, okay, in that case the body is trying to compensate. So this is called compensation. And remember, the compensation is generally partial. Compensation is generally partial. Okay, so remember, first you have to make the diagnosis of acidosis or alkalosis, then you have to make the diagnosis of whether it is metabolic in nature or respiratory in nature. Once you have made the diagnosis, if required, you try to identify whether the compensation is there or not. In this case, your expectation is, in this case, PCO2 value being more than 40 and PCO2 value is going to less than 40. All right, so this is how you can simply identify whether it is acidosis or alkalosis and whether the compensation is there or not. And what about the anion gap? Okay, so based on the value you can quickly calculate the anion gap. So if you look at the values here, number one value 7.16, this indicates we are looking at acidosis. So first finding is we are looking at acidosis. Second, in acidosis, either the PCO2 should be high or the bicarbonate should be low. Now, in this case, we find that PCO2 is not high, but bicarbonate is low. So, this becomes the primary diagnosis, means we are looking at metabolic acidosis. Now, PCO2, instead of being high, it is becoming low. That means there is compensation. So, respiratory compensation is there, and anion gap. Anion gap value comes out to be 135 minus 100 plus 5, which is 135 minus 105, which is 30 milli equivalent per liter, which is quite high. So we are looking at high anion gap. So your option 1 is the correct answer, metabolic acidosis with the respiratory compensation with high anion gap. So the flow chart, very simple, straightforward, which can help you to make the diagnosis and to identify compensation, and the formula for anion gap, which will help you to identify what is the level of anion gap, whether it is a normal range or it is increased. Okay, so this is the first very important question. Every paper we have one question on acid base disorder, so there is no reason for you to not look up at this acid base disorder question and mark it correct. It is very simple to do. If you follow this flow chart, then very easy and simple to do. Don't forget the normal values, because the normal values will not be provided in the question. You have to know these values, you have to know these values. Only then you can identify whether the increase or decrease in the values is happening. Okay, so that's one very important question. Second very important question is related to the blood sampling, order of draw, which tube for which analyte, and which analyte is added for which type of sample, or in this case it can be which tube to be used for which type of sample. Okay, so we keep getting the different types of color tubes. The primary sequence that you have to remember: first, red vial oblique gold top vial, red vial or the gold top vial. This red or gold top vial is the one which is going to give you the serum, and therefore you will do the biochemistry immunological test in this one. The red top or the gold top vial is going to have the the clot activator. It is going to have the clot activator in it, the clot activator for the formation of clot, so that you can get the serum. So first is the red oblique gold vial, where you get the serum. It contains the clot activator. Then after that, for our purpose, next would be the lavender top vial or the pink top vial. In this case, you get the whole blood, and it contains the EDTA. to prevent the coagulation of the blood, when you want to do the complete blood count. Okay, so we commonly use the lavender top vial, but lavender top vial can be replaced by pink top vial. Both of them can be used interchangeably. The third in the sequence of the routine sampling is the gray top vial. Gray top vial contains sodium fluoride plus potassium oxalate or the EDTA, and it is for estimation of the plasma glucose. Okay, so these are the three routine samplings that we are doing. In addition to that, if you are required to do the blood culture, then it should be the first. If you are required to do the coagulation studies, then it should be the second. Okay, so in actual sequence, first is blood culture. However, we are not doing them normally. And second is the blood coagulation profile. So if you are preparing a patient for surgery, then these two have to be done before you perform the test for the serum, for the whole blood, and the plasma glucose. Okay, so this is the sequence which has to be followed. In this case, they've asked about the anticoagulant. In this case, they've asked about the anticoagulant. For the gray top vial, the gray top vial will have the sodium fluoride with the EDTA. Sodium fluoride with the EDTA. So this is your correct answer. Sodium fluoride with EDTA is the vial, is the analyte which is present in the gray top vial. Okay, red top vial will have the clot activator, the lavender top vial will have the EDTA, and the gray top vial will have sodium fluoride with either the potassium oxalate or the EDTA. Any of the two may be present. In case of the tube number 2 for coagulation, it is having the blue top, and it is going to be having the sodium citrate as the buffer. Citrate is going to be there for the buffer. Third very important topic is related to nutrition. Okay, so in this case, the very important concept that you have to know is, what do you mean by balanced diet? What do you mean by balanced diet? And here you have to remember the composition of the diet in terms of the calorie that they provide. So how much calories as a percentage should come from carbohydrate, how much calories as a percentage should come from proteins, and how much calories as a percentage should come from the fats. For carbohydrate, typically we say 50 to 60%, on an average about 55%. For proteins, you say 10 to 15%, and for fats it is 20 to 30%. 20 to 30% normally should come from a balanced diet. All right, so if you want to talk about high fat diet, if you want to talk about high fat diet, the value has to be higher than this. So until as the value is higher than 35%, you cannot call a diet as the high fat diet. Okay, so in this case, obviously the answer becomes more than 35%. But another important aspect of this balanced diet is, majority of the meal that we consume is not actually balanced. Rather, we have much higher values of carbohydrates. So how do you identify whether a meal is carbohydrate rich or not? For that, you will be given the value of RQ. RQ is normally 0.85. RQ is normally 0.85, but when the high carbohydrate diet is there, or carbohydrate rich diet is there, in that case it becomes closer to 1. So by looking at the RQ value, you can identify whether you are taking a balanced diet or the carbohydrate rich diet. The RQ is not typically used to identify the fat rich diet, but rather it is more tilted towards the identification of the carbohydrate rich diet. So either you can get the question on balanced diet, or you can get the question about RQ in terms of the balanced diet or the carbohydrate rich diet. Okay, so remember these 2 points in your mind. Sometimes you may also get to calculate the calorific value of food, so you have to keep that point also in mind. And when you're doing the calorific value of the food, you should remember, for carbohydrate you have to calculate 5 calorie per milligram or kilocalorie per gram, depending on what is given in the question. In the question it will be grams. All right, so there the unit should be kilocalories. Similarly, for proteins, it will again be 4 calories 4 calories per milligram or 4 kilocalories per gram. For fats, it should be 9 calories per milligram or kilocalorie per gram. So values are 4, 4 and 9 for carbohydrate, protein and fat. If you have to calculate the calorific value of the food. So on nutrition, commonly you're getting the question on balanced diet. Sometimes you get the question on RQ and sometimes you can get the question on the calorific value of the food. A meal is given. For that meal, you will be required to calculate the calorific value. Again, in that question, these normal values for the purpose of calculation will not be provided. You should be knowing these values. If you don't know these values, then you cannot do the calculation. Then very commonly we get this question about the congenital defects. One of the commonly asked questions is the cause for lactic acidosis. In addition, the lactic acidosis itself is an important question. So what are the conditions in which you normally see the lactic acidosis? So when you talk about lactic acidosis, what you have to remember, any mitochondrial DNA disorder, any mitochondrial DNA disorder will present with lactic acidosis. In addition, any cause which interferes with the pyruvate dehydrogenase complex, any cause which interferes with the pyruvate dehydrogenase complex is also going to cause the lactic acidosis. Some of the important causes are decreased vitamin B1, presence of certain inhibitors like arsenite and mercuric ions, and the congenital deficiency of the enzyme. So these three are another set of important causes for the lactic acidosis. Obviously, you can see out of these, the congenital cause is the congenital deficiency of the enzyme pyruvate dehydrogenase. Alright. So remember, anything which affects the electron transport chain, anything which causes mitochondrial DNA disorder, anything which disrupts the pyruvate dehydrogenase complex, all of these are going to present with the lactic acidosis. Okay, lactic acidosis may also be seen after strenuous exercise. However, it is transient. The body will quickly compensate. The muscle production of lactic acidosis is soaked up by the livers as soon as you enter the resting stage, and this lactic acidosis is not long-standing in nature. Then question about the B9 and B12 deficiency. You are regularly asked to distinguish between B9 and B12 deficiency, and like this you can get the true false statement. In B12 deficiency, the true statement is, and then you get the various statements. So when you get the question on B9 and B12 deficiency, what you have to remember is like this. For B9 versus B12, the parameters which come into consideration are, first, the megaloblastic anemia. First is megaloblastic anemia. Alright, the megaloblastic anemia is seen in B9 deficiency and B12 deficiency also. Why? When the B12 deficiency is there, there will be folate trap. Folate trap will cause the megaloblastic anemia. Then you have the homocystinuria. Again, homocystinuria is seen in B9 and therefore it is seen in B12, because in B12 again you will have the folate trap. So all the features of B9 deficiency will be there in B12 deficiency as well. But in addition to these two, you are also going to have the methylmalonic aciduria. For the metabolism methylmalonic acid, the B12 is required. So if the B12 deficiency is there, then the methylmalonic acid will accumulate and it will cause the methylmalonic aciduria. And last is the neuropathy, subacute combined degeneration of the cord. This is not a feature of B9 deficiency, but it is a feature of the B12 deficiency. So these differences between the B9 and B12 deficiency you should know, so that you are able to distinguish between them. Very frequently we get the question about B9 and B12. Either they can be standard to full treatment, or you get a clinical case where you have to identify whether the B9 or B12 deficiency is the main problem causing the presentation. Okay. One extra point you should keep in mind: if there is B12 deficiency and you add the folic acid, you add B9, the neurological features, whatever neurological signs and symptoms are there, they will be aggravated. Please keep in mind the neurological signs and symptoms will get aggravated if in B12 deficiency you add the B9 without giving the B12 supplementation. Okay, so there's an extra point to keep in mind about the B12 deficiency when compared to the B9 deficiency. Very, very important, very frequently asked question. So you should must definitely know about this. Okay, then another very, very important question is about the glycogen storage disorders. Glycogen storage disorders is another very, very important question. We keep getting the question on glycogen storage disorders. Sometimes we get the clinical case, sometimes you get the straight one line question, okay, this is a diagnosis, which enzyme is deficient, or sometimes you get the enzyme deficiency and you're asked which disease is caused by this deficiency. And sometimes, like last time, you can get the whole set and you have to identify the correct combination, okay, which one enzyme deficiency is there with which particular disorder. So in Cory's disease there is deficiency of debranching enzyme. So branch structure in liver biopsy will be seen in Cory's disease. In McArdle's disease there will be exercise intolerance. In Pompe's disease, there is accumulation of glycogen in lysosome, and in von Gerke's disease, there is hypoglycemia with lactic acidosis. There is hypoglycemia with lactic acidosis. For von Gerke's disease, you should also remember that there is increased level of the uric acid. Uric acid values are quite high. Uric acid values are quite high, and uh, the fainting episode. Fainting episode is another characteristic feature in the von Gerke's disease. Sometimes the presentation may be described as doll-like facies of the patient. For the patient, this term doll-like facies is provided. Similarly, in exercise intolerance, along with accumulation of glycogen in lysosome, what you have to look out for is the cardiomegaly. It is one of the characteristic and important features because cardiomegaly is ultimately going to be the cause for early death in these patients. You get to see early death, the cause being the cardiomegaly. Cardiomegaly is the cause for early death. Okay, so you have to keep that in mind. In McArdle's, there is exercise intolerance and enlargement is limited to the muscles. In Cory's disease, the branch structure of the liver is seen, branch structure of the glycogen is seen in biopsy, and we find fasting hypoglycemia. Very characteristic feature is there, which is called the fasting hypoglycemia. So these are some of the commonly asked cases. Rarely you can be asked about glycogen storage disorder 0. In 0, there is no organomegaly and there is no glycogen stores. There is no glycogen stores in the liver. Okay, remember, no organomegaly, no glycogen stores, and there is hypoglycemia in between the meals. This is the only condition where in between meals you are having hypoglycemia, means immediately after the post-fed state. As soon as you enter the post-fed state, after the absorption from the diet is complete, immediately the patient will start going into the hypoglycemia. So if this sort of presentation is there, then you can start thinking about glycogen storage disorder type 0, where the enzyme glycogen synthase is not there. Okay, where the enzyme glycogen synthase is not there. In your notes, I've given you the enzymes for the different disorders, so you should make note of those enzymes. In Cory's disease, the debranching enzyme is deficient. In McArdle's, the myophosphorylase is deficient. In addition to that, you have to look about after the Anderson's disease, which is not there in the options. In Anderson's, the branching enzyme is deficient. In Anderson's, the branching enzyme is deficient. However, the Anderson's is generally not asked. The Anderson's disease is generally not asked. Mostly we are getting the questions on Cory's and the von Gerke's and the Pompe's, rarely on GST type 0 and the McArdle's. Okay, so these are the ones which are getting routinely asked in your exam. Another very common question is about the enzyme inhibition. Enzyme inhibition is very commonly asked in the exam, where they ask you to differentiate between the different types of reversible inhibition. Okay, we have discussed this in class, if you've attended the class, where we talked about the reversible and the irreversible inhibition. And very frequently they will give you what is known as the Line-Weaver-Burke plot. Line-Weaver-Burke plot, also known as the double reciprocal plot, because on both the axis you have the reciprocal values, so it is also known as the double reciprocal plot. Okay, now I'm sure all of you know that on this plot we have to look at the intercept on the y-axis and the intercept on the x-axis. The intercept on the y-axis is 1 upon Vmax, intercept on the x-axis is minus 1 upon Km. And to interpret these graphs, you have to remember two important points. What are the two important points? In competitive inhibition, the Vmax is normal. In non-competitive inhibition, the Km is normal. Means when you're talking about competitive inhibition, the intercept on the y-axis should remain the same. So if you have two graphs crossing at the same point on the y-axis, this means the Vmax is same. You're looking at the competitive inhibition. Whereas if Km is normal, then the point on x-axis will be same. If you see two graphs where the common point is on the x-axis, then you're looking at the non-competitive inhibition. So in this case, inhibitor A is competitive and B is the non-competitive. Given the graph in the notes where we mention what is happening to the Km and the Vmax, the three types of inhibition being the competitive, the non-competitive, and the uncompetitive inhibition. These are the three types of inhibition that will be asked. All of these are type of the reversible inhibition. You should also know a little bit of one type of irreversible inhibition, and that irreversible inhibition is the suicide inhibition. Suicide inhibitors is one of the commonly asked question from the irreversible inhibitors. Otherwise, normally we don't get the question on the irreversible inhibitors. Okay, so you should look up the suicide inhibitors, where what is happening initially there is competitive inhibition, followed by competitive inhibition there is a process of catalysis, and following catalysis the metabolite which is formed after catalysis attaches covalently to the active site. It attaches covalently to the active site. Okay, so this is a very specific pattern of the inhibitor, and therefore very frequently asked. Also a unique phenomena where inhibitor is getting destroyed. You're metabolizing the inhibitor, so inhibitor is getting destroyed. Okay, so this, because of this reason, very commonly get the question on the suicide inhibitors which fall under the irreversible inhibition. The other three, competitive, non-competitive, and competitive, are under the reversible inhibition. Again, another very commonly asked question is about the primary hyperlipoproteinemias. Now, in this question on primary hyperlipoproteinemias, the two subclasses are asked very frequently. You have this table in your handout that I've given you, the generic classification, which lipoprotein is increased and which lipid is increased. The ones which you have to focus on are type 1 and type 2A. In the exam, these are the two which are going to be asked. These are the ones which are going to be asked, 1 and 2A. In one, what is happening? There is lipoprotein lipase deficiency. Now, for lipoprotein lipase deficiency, you have to keep in mind there are three possibilities for the lipoprotein lipase deficiency. Number one, there is gene defect for the lipoprotein lipase. Number two, the lipoprotein lipase has to travel to the surface, so there can be a transport defect. And lastly, the lipoprotein lipase is activated by ApoC2. So if there is ApoC2 defect, then also the lipoprotein lipase will not work. Okay, and in these cases, you are going to get the cutaneous or subcutaneous xanthomas. So if the question mentions the cutaneous xanthomas, then you're looking at the lipoprotein lipase deficiency, where chylomicron is elevated and triacylglycerol values should be high. The second case, type 2A, hypercholesterolemia or the familial hypercholesterolemia or the primary hypercholesterolemia can again be due to two reasons. Either the LDL receptor deficiency is there or there is mutation in the ApoB100. In both the cases, LDL cannot be taken up, cholesterol levels will be high, and what you get to see is the tendinous xanthoma. So if it mentions xanthoma on the Achilles tendon, if it is mentioning the tendons where the deposition is happening, then you know we are talking about the hypercholesterolemia. In addition, there will be increased family risk or family history of the cardiac event. Okay, so those parts may be given in the question. So 1 and 2A are the ones which are most commonly asked. If you look at the previous question, here they are asking which gene defect causes familial hypercholesterolemia leading to the increased risk for cardiac events and tendinous xanthoma. So tendinous xanthoma, we said the ApoB100, and along with that the LDL receptor. These are the two which are going to cause the familial hypercholesterolemia. These are the ones which are going to cause the familial hypercholesterolemia. Then we frequently get question on special products of the amino acid. Normally we think of amino acid as a building block for the proteins. Amino acids will get attached, will form the chain or the polypeptides and the proteins will be formed. But sometimes the amino acid can be activated by enzymatic reactions and these products are also metabolically active. These are known as the special products of the amino acid, where we talk about the gluconeogenesis, where we talk about the formation of creatine, the formation of nitric oxide by the nitric oxide synthase, the formation of purine ring, the formation of heme, the formation of histamine, the formation of this acetylmethylmethionine, methionine, and the formation of serotonin, melatonin, niacin, vitamin D3, the formation of the catecholamines including the dopamine, norepinephrine, epinephrine, formation of the thyroxine hormones, formation of melanin, and formation of the GABA. So these are some of the commonly asked questions. They ask from which amino acid these molecules are going to get derived. Out of these, you have to make special note for GABA and the histamine. For these the specific reaction is asked, by which reaction these conversions are happening. So both of them are getting converted by the action of decarboxylation. So please remember, both of them are getting converted to the product from histidine to histamine and from glutamate to GABA by the reaction of decarboxylation. Okay, so the special products from which amino acid they are coming and the reaction involved in the formation of GABA and the histamine, these are commonly asked. So if you look at the summary point for creatine synthesis, you are making use of the three amino acids. You are making use of arginine, you are making use of glycine, and on the next page you can see you are making use of the methionine. You are making use of the methionine. Similarly, you can get the question on heme synthesis. If you get the question on heme synthesis, in that case you are making use of succinyl coenzyme A, glycine, and ferrous iron Fe2 plus. Later on we will get a question on the heme degradation also. So I'll quickly highlight here itself. In heme degradation, what you get is biliverdin. Along with biliverdin, we get the carbon monoxide. This is possibly the only physiological reaction where carbon monoxide is produced, and the ferric iron. Oh, it went away. I'm so sorry. And in heme degradation, what you get is the ferric iron along with carbon monoxide and biliverdin. Okay, so remember, for heme degradation, this is what is required. So looking at this question where they're talking about reaction involved in getting the amino acid derivatives histamine and GABA, please note the reaction is decarboxylation. The reaction is decarboxylation. Okay, then we keep getting question on the topic of epigenetics. The epigenetics is the covalent modification, occurring in two places. One, this covalent modification is occurring in the histones. So histones are getting modified. And second, the DNA. In DNA, only one type of change is seen, which is the methylation. Whereas in the histones, you can see different types of modification. You can see the acetylation, you can see the ADP ribosylation, you can see methylation, you can see phosphorylation, you can see citrullination, you can see monoubiquitination, you can even see addition of proteins like SUMO, which may be added. Sometimes it is known as sumylation. So, you have different modifications in histones, but in the DNA, only one change, and that is the DNA methylation. Only one change, and that is the DNA methylation, right? So this DNA methylation is always going to cause the suppression of gene expression. Always, whenever there is DNA methylation, it will cause suppression of gene expression. The changes occurring in the histones are having the variable effects. It depends on which histone is involved, in which chromosome it is involved, within the chromosome, where it is placed, and whereby it is getting involved. So the effects of histone modification are variable, but the effects of DNA methylation is always the same, that is suppression of gene expression, or sometimes also known as the gene silencing. Why? These CPG islands where this methylation is occurring, these are enhancers responsible for enhancing the expression of the gene. So when you do methylation, enhancers shut off. When the enhancer shut off, the expression will also get shut off. So the gene expression is getting silenced when you do the methylation for the CPG islands. CPG islands work as enhancers. They can be upstream, they can be downstream from the gene. They need not be only upstream, they can be downstream as well. Okay, so remember, in the DNA there is only one type of change which is occurring, and that is methylation. Only one type of change in the DNA, that is methylation. Other type of changes do not occur in the DNA. And then we get the question on the mutations. Okay, mutation is another very hot topic. In mutation, we have the two important types of mutation which are commonly asked. First is the point mutation, also known as the base substitution. The point mutation, also known as the base substitution, which is the most common type of mutation. Along with that, you get the insertion deletion type of mutation. Either one nucleotide or mononucleotides are inserted, or one or more nucleotides are deleted. So these are the two most common types of mutation that you are going to come across. Now about the insertion deletion, there is a very peculiar phenomenon which happens. Normally when there is insertion or deletion of nucleotide, there is a shift. There is shift in the reading frame. There is shift in the reading frame. There is shift in reading frame of the sequence of the nucleotides. All right, but if this insertion deletion occurs in multiples of 3, then there is no shift. Then there is no shift in the reading frame. If the insertion deletion occurs in multiples of 3, then there is no shift in the reading frame. So in this question, you have to look for multiples of 3. The question says which number of insertion will not result in shift in the reading frame of the genome. So you have to look for multiples of 3. The multiples of 3 in this case is number 9. Multiples of 3 in this case is number 9, which is your correct answer. Okay, so very commonly asked about the effect of insertion and deletion. Nowadays, with the increasing availability of better treatment options, so more options for treatment, more drugs being available, more enzyme replacement therapies being available, we try to identify the metabolic disease in the children via screening. Now, the challenge is to test for a huge number of conditions in one single sample, because for children you cannot take out too many samples. So in this context, the ideal tool is the tandem mass spectrometry. Basically, what is happening here, you have the mass spectrometer and another mass spectrometer in series. So you have two mass spectrometers, they are arranged in series. What the first mass spectrometer does, it separates all the different analytes which are there in the serum. And once the separation is done, it is fed to the second mass spectrometer, which analyzes each of the analytes which have been fed to the second mass spectrometer. What we're looking for here is a twofold identification. Is anything missing? What was supposed to be present normally in enzyme and product, something which is missing, and presence of abnormal metabolites which are not supposed to be there but they are present. So we are looking for substances which are normally supposed to be there but they are missing, and we are looking for analytes which are normally not supposed to be there but they are present. Okay, so in this way we can identify more than 50 different inborn errors of metabolism by one single DBS, where DBS stands for the dried blood spot. Using one single dried blood spot which can be obtained by heel prick, you can identify more than 50 inborn errors of metabolism. So it is a very high efficiency technique for the screening. If you get positive result, then obviously you can go for the confirmatory tests, but for screening purpose, for mass screening, this is an ideal tool. Very small amount of sample required for detecting a huge number of diseases. For detecting a huge number of diseases, you could require a very small amount of sample. Okay, we just mentioned about the product of heme catabolism. I told you the ferric iron is seen, biliverdin is seen, carbon monoxide is seen. Carbon dioxide is not seen. Please keep in mind, carbon dioxide is not produced. This is probably one of the only physiological reactions where during the reaction carbon monoxide is produced. Normally we expect the carbon dioxide to be produced, but in this case it is a carbon monoxide which is getting produced. Alright, so please bear that in mind. Now, the diabetes is a big pandemic today in our country, and that is why we are getting a lot of questions about the diabetes mellitus, how it is regulated, which exercise you ask the patient to do, what way the exercise is going to help, which hormones are activated, if due to that hormone, what is the effect on the TG level, what is the effect on VLDL level, how they are getting elevated. So, in the background of this information, what you have to remember, the insulin is supposed to have action on two very important lipases. First is the hormone sensitive lipase, alright, commonly written as the HSL, and second is the lipoprotein lipase, which is written as LPL. Okay, the hormone sensitive lipase is present within the tissues. Lipoprotein lipase is attached to walls of capillaries. So where will the hormone sensitive lipase act? It will act on TAG, which is present in the tissues, whereas the lipoprotein lipase acts on the TAG, which is present in the lipoprotein in circulation. As the name tells you, it is a lipoprotein lipase. So the lipoprotein which is circulated in the blood, within that the triacylglyceride is cleaved to release the free fatty acid for the use of tissues. Now insulin will activate the lipoprotein lipase, so they deliver this fatty acid to the tissues, and at the same time it will inhibit the hormone sensitive lipase. This is what is happening normally physiologically. However, when you have a case of diabetes mellitus implies that there is decreased insulin. Either functionally it is decreased because of insulin resistance, or because of absolute decrease. In type 1 DM, the insulin is not being produced. Okay, so whatever manner is responsible, net effect is the functional insulin availability is less. In that case, what is supposed to happen physiologically? Opposite will happen. Insulin is inhibiting hormone sensitive lipase, insulin gone, hormone sensitive lipase will increase. So there is increased action of the hormone sensitive lipase, and normally it is activating the lipoprotein lipase. So when the insulin is less, lipoprotein lipase activity will be decreased. So in this case, you find decreased action of LPL and increased action of HSL. So this triglycerol from the tissues is getting released into the blood. It will go to the liver. Liver will repackage it in the form of VLDL and will release the triglycerol. That is why the liver produces more triglycerol and VLDL, because it is getting the free fatty acid in the blood. That free fatty acid is coming in the blood, which will be repackaged by the liver. So this concept about the activation of HSL and LPL is very, very important. How they are activating, in which condition, which hormone will be activated, which hormone will be inhibited, is very, very, very important to remember. And repeatedly we are getting the question along these lines. Urea cycle is another important inborn error of metabolism. It is not a rare condition. So frequently we keep getting question on the urea cycle. Frequently we keep getting question on the urea cycle. Now when we talk about urea cycle, there are two very, very important alternative routes for nitrogen excretion. Two very important alternative routes for the nitrogen excretion. Okay, so these two are repeatedly getting asked in our exam. In this question, what you can see, the administration of phenyl butyrate is done, and it will help to decrease the ammonia formation. So when you give the phenyl butyrate first gets converted into the phenyl acetate, implying that phenyl butyrate is actually a prodrug. It is not the active molecule. It will get converted to the active molecule. Okay, this phenyl acetate then combines with glutamine. It combines with glutamine to form the water-soluble substance known as phenyl acetyl glutamine. Because this is freely water soluble, this will be excreted in urine. It will be excreted in urine. Similarly, you can have another molecule by the name of sodium benzoate. Sodium benzoate can be there, which will combine with glycine. Once it combines with glycine, it will form the hippuric acid. Hippuric acid is also freely water soluble, and therefore it is also excreted in the urine. So these two are very, very frequently asked. Remember, commercial preparations are available for these two. Commercial preparations are available for the phenyl butyrate and sodium benzoate in combination. In combination, the commercial preparation is available, which can be given during the episodes of urea cycle disorder, because urea cycle is an episodic disease. Whenever there is a high intake of protein diet, and those are the times when the child will present with the features of the urea cycle disorder. So at that time, you can give the combination of phenyl butyrate and sodium benzoate, which is available commercially. Okay, please remember these two names, where which substance are they reacting with, and what are the product, what happens to the final product, okay. Sometimes they can ask about phenyl butyrate, sometimes they can ask about the sodium benzoate. You should remember both of them. I think that is all the questions that we had for you today. Okay, so I think that was the last question that I had for you today. 15 questions we had promised. I think I've discussed more than 15 questions, but these are some of the very, very high topics. Very, very high topics. One high topic which I have not covered here is about the B1 and B3 vitamin deficiency. So if you want to do a quick revision of your biochemistry, I'll advise four things which you must do. Four things which you must do. First is, please revise the vitamins. Vitamins is a very, very high topic. At least four questions guaranteed they're going to come. Sometimes it can go to 6, 7, 8 even. So please spend 20-30 minutes, revise the content on vitamins which is there. If you've not attended my class, quickly review the lecture. It is a small lecture, so you can quickly review the vitamins, or you can look at the handbook where the notes are there. Just quickly run through the notes for the vitamins. Second is the cluster of inborn errors of metabolism. In each of the different metabolisms, in carbohydrate metabolism, we have the mucopolysaccharidosis, we have the glycogen storage disorders, we have the galactosemia and the fructose related metabolism, hereditary fructose intolerance, and essential fructose. In lipid metabolism, we have the sphingolipidosis, we have the primary hyperlipoproteinemias. These are the ones which you have to look at. In amino acid disorder, you have to look at the urea cycle disorder and the metabolism cluster of phenylalanine and tyrosine, along with the maple syrup urine disease. Okay, so these are some of the very important clusters which you should remember. Clinical cases are coming from these IMs. At least 4 to 5 questions will come from the IM. Then few pages of general biochemistry in your notes, first few pages, and it is going to give you 4 to 5 questions. General biochemistry is something which you cannot afford to miss. If you have less time for revision, please revise the general biochemistry. And finally, table on the rate limiting enzyme for the different metabolic pathways. Very critical. One question guaranteed to come from the table on rate limiting enzyme for the metabolic pathways. So I'll give you some broad topics in these questions that I have highlighted. I've talked about associated topics which are also likely to come, how the questions are going to come. And these 4 broad topics, very important, most likely to land up in your exam. So please don't miss these 4 topics. Please revise them properly before you go for the exam. You'll notice I'm not talking about the whole metabolism, but these 4 the most high, very critical topics you must revise. You're going to get 90% of your questions from these 4 topics. You can take it in writing. 90% questions from these 4 topics. Okay, so that is all I have for you from my side today. Thank you very much and best of luck.